And welcome to the TRSP Webinar Series. This is the final webinar in our series for 2023. And I'm going to be talking today about improving clinical and functional outcomes for people living with psychosis. And these are all data and information collected through our New South Wales Tertiary Referral Service for Psychosis, of which I'm the clinical director. So before we get into the talk, I'll just go through a little bit of housekeeping and a little bit of background and introductions. So my name's Julia Lappin. I'm a clinician and researcher with expertise in psychotic illness, and I've worked with people with psychotic illness for over 20 years. I hold a position as clinical director for the Tertiary Referral Service for Psychosis, which is hosted by South East Sydney Local Health District. And I'm also an associate professor within the discipline of mental health and psychiatry at NSW Sydney. So I'll be talking today about the TRSP and our aims to improve lives for people living with psychosis, including through capacity building, through webinars such as these, which provide education and skill development support for clinicians working with people who are living with psychosis. The TRSP Webinar Series is supported by Mindgardens, which is a partnership between members Neura, Black Dog Institute, UNSW Sydney, and the Southeastern Sydney Local Health District. So before we get underway, I'd just like to thank you for joining. You'll be able to enter questions and comments in the Q&A and the chat during the talk, and there will be some short polls at the end, which we really encourage you to complete because they help us plan the programme of talks and topics which you might like to see in the TRSP webinar series for 2024. And finally, this event is recorded, and we'll distribute a link to the event video within 2 weeks to everybody who provides us with an email address. You can opt out of our communications at any time with a return email with unsubscribe in the subject line. So I'll just start away now and provide you, first of all, an outline of the talk for today, but I'll just begin with an acknowledgement of country. So I acknowledge the strength and resilience of Aboriginal and Torres Strait Islander people who are the traditional custodians of the diverse countries from which we're joining this meeting today. I'm privileged to be calling from the land of the Gadigal people of the Eora Nation, and I pay my respects to elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander people present today. I also acknowledge people with lived experience of mental ill health and recovery, and the experience of people who have been carers, families, or supporters. So today I'm going to try and introduce some key concepts which we work with closely in the Tertiary Referral Service for Psychosis. I'll talk first of all about complex psychosis and treatment resistance, and then talk about some work that I conducted in my early years of research, looking at people with first episode psychosis and following them up over 10 years to see what life was like for them 10 years after their illness began. Then I'm going to talk quite a lot about the Tertiary Referral Service for Psychosis, what we do, how to make a referral, what we've done for people that we've seen so far, and what the outcomes look like for those people a year after they've seen us. And then right at the end, I'm going to talk a little bit about research projects that we have running in TRSP as part of our clinical research programme. So I'll start with introducing the concept of complex psychosis. We all, I think, know what it means to have psychotic symptoms and have psychotic illness, but complex psychosis is a separate term which is used to refer to people who have a diagnosis of psychosis that is characterized by severe and treatment-resistant symptoms of psychosis, and functional impairment. And this is really important because a lot of the people that we care for in public mental health services do have complex psychosis. They have these enduring symptoms which are distressing. And despite often our best efforts to provide treatment for them, sometimes they can have symptoms that persist, and certainly functional impairments that are continuing to impact on their quality of life and contribute to the very high levels of social exclusion in this group of people. What do we mean by the term treatment resistance, and how does that overlap with complex psychosis? They are overlapping concepts, but it's important to note that many people who look as if they're not responding to treatment may not actually have true treatment resistance. So true treatment resistance is, you know, I've said it many times, and I was recently teased by our registrar group for saying it too many times, but treatment resistance is about people who have had 2 trials of antipsychotics, one after the other, with adequate doses, and who still have psychotic symptoms. So is that sometimes things get in the way of our being able to make that diagnosis. For example, people may not be on treatment, they may not be taking the treatment, or they may not have the correct diagnosis. And this gives rise to the concept of pseudo-resistance. So people who may be thought to be treatment resistant who are actually not getting treatment or aren't getting treated for the right diagnosis. And it's very important that we explore these issues to make sure that we've thoroughly examined whether people are compliant and we're treating for the correct diagnosis or diagnoses before we confirm a diagnosis of treatment resistance. So the reason for saying that is that in order to provide a really comprehensive approach to treating severe psychosis, we shouldn't only see people who have treatment resistance alone. We should see a broad scope of people, because we may through investigation learn that some have treatment resistance, others can respond to a variety of treatments. And that indeed is what we try to do in TRSPs. We do see a lot of people with treatment resistant illness, but we also see a lot of people who have difficult to treat or complicated psychotic illness because they have comorbid physical health issues or comorbid mental health challenges such as significant childhood trauma, OCD, ADHD, a whole range of things. So having introduced those concepts, I'm going to move on to provide some epidemiological data on how common complex psychosis is. And this is work that I completed, I was going to say 10 years ago, it's probably closer to 15 years ago now, as part of my PhD, which I completed at the Maudsley Hospital in London with a team of researchers who worked for many years with people with psychotic illness. And what we did in this study, which was called ESOP, was we identified lots of people who came to services with their first episode of psychosis over a 2-year period. We collected information on over 500 people from Bristol, Nottingham, and London, and we followed them up over a 10-year period to see how often they were experiencing psychotic symptoms, how many of them were working, how many of them were functioning, how many could be said to have recovered from their illness. And this chart summarizes illness course for those people, those 550 people that we followed up over the 10-year period. And really what I want you to look at in this graph is just the top black line. So you see that the axis, the vertical axis, is talking about how many months did the person experience symptoms in a given year. So that can go up to 12. You can see that these people in the black line throughout the 10-year follow-up, which is time along the bottom axis, throughout that 10-year follow-up, these people were experiencing symptoms pretty much every month throughout that 10 years. So these are people with chronic psychosis, and these are the people that make up a huge proportion of the people that we treat in public mental health services. These are the people that we continue to care for, because people who get better are discharged to the community, to GP primary care. Sometimes they come back. Many people have relapsing and remitting illness, and those are the people in the red line at the bottom. You have maybe several months a year, or different patterns of episodes of illness that require care, but not continuously, perhaps. So these data are really important because they were collected from an unbiased sample of people. Everybody coming in the doors of the public mental health services who had a first episode psychosis was included and followed up. So we know that roughly 1/3 of people will have persistent psychotic illness symptoms every day, every month for the next 10 years, about 1/3 of people. And about 2/3 will have that other pattern where they have relapsing, remitting illness. Very few, less than 8%, never have another episode. And I think that's really important for us to be aware of. Psychosis, for most people, is a chronic illness, or at least a relapsing and remitting illness. So how can we use information that we have when people first present to help us understand who are the people most likely to get better or most likely not to get better? Well, importantly, treatment helps. So we studied how people did if they were all treated naturally in hospital. So we just observed them over the subsequent period. We looked at how people did and what predictors there were of how they were doing at 10-year follow-up. And we examined recovery, both in terms of how they were doing clinically, what symptoms did they have, and separately, how they were doing functionally. Were they working? Were they in a relationship? We kept those two outcomes separate, though they do overlap, but we wanted to look at the two separately. And we found, looking first of all at symptoms, that only 46% of people were free of symptoms in that entire 10-year period for a minimum period of 2 years. So less than half get well and stay well for a 2-year period at any point. So you can see that most people are having symptoms on and off or throughout. And what predicts those people is that they responded well to treatment within their very first 12 weeks of care for first episode psychosis. So what that really means is that some people respond to treatment, and if they're going to get better on treatment, most of them will do so within, or show some signs of improvement within that first 3 months of their first episode. Other people, as we know, don't get better with that first treatment, and it may be because they're not taking it, but often it's because they're taking it and it's not working for them. Another baseline factor that made it more likely that you would have a 2-year period of wellness over the following 10 years was that your diagnosis, rather than being one of schizophrenia, was one of depression. And this aligns well with evidence that we've collected, many people have collected over the world over many years, observing people with psychosis, that schizophrenia is that sort of poorer prognosis. People with affective symptoms, whether manic or depressive, tend to do better, tend to show more chance of improvement and recovery. Looking separately now at how many people had functional recovery, we used employment as a proxy for this. And that was achieved by less than 10% of people at 10-year follow-up. So very, very few people are employed at 10 years. We also looked at the GAF score, which you may be familiar with. It's also called the SOFAs. This is a measure of how able people are able to manage at work, in their relationships. Lower scores mean they're not really managing their ADLs. They may stay in the house on their own all day, have no friends, be on the DSP, for example. And we set our bar for functional recovery really quite low at a GAF lower than 60. So that's still quite a lot of problems, probably not working, but may have a few relationships and may be able to get out and about most days, sometimes with support. And that fairly low bar was only achieved by 40% of individuals, which means that 3 in 5 individuals are doing even worse than that. So this is no surprise to us. We know that psychosis is, for many people, a chronic and enduring illness. It causes distressing symptoms, and it also causes functional impairment. What were the predictors of people who did well functionally? Well, similar to the clinical recovery, responding to treatment within the first 3 months following first episode predicted good functional recovery at 10 years. And also, interestingly, being in a site which was less urban, and we see this in many studies of psychosis around the world too, that high urbanicity makes people more likely to develop psychosis and more likely to have poor outcomes. And it's probably something about the stress of living in a city. Often people can feel more lonely and are less supported away from community networks and families, living quite an isolated existence in cities. And finally, affective symptoms again. So a diagnosis of mania was more likely to result in people down the track being more likely to be able to have functional recovery. So I've included these data because I just want to, I suppose, explain the story a little bit of why I've come to feel very passionately about trying to improve both clinical and functional outcomes for people who have psychotic illness. First of all, because we see that many people have this illness for very many years, and because there is great need. They have distressing symptoms and they have very impaired function. And that has really been one of the main reasons why one of the underpinnings in my interest and my passion to set up the New South Wales Tertiary Referral Service for Psychosis. And I'm going to start talking a little bit about our work now. And while I'm the clinical director, I am only one of a team of many skilled senior clinicians. We work as part of a multidisciplinary team, and we can offer really holistic assessments and recommendations from a medical point of view, but also a physical healthcare point of view, social work, family support, neuropsychological input, occupational therapy, and of course, very importantly, peer support work, because we have all those members of our team who would be involved in any person who is referred to us. So what is it that we are? What do we try to do? Well, we're a statewide service in New South Wales. We've been up and running for almost 3 years now, and we work with adult mental health teams, public, hospital or community. And what we're really trying to do is improve the lives of people living with complex psychosis. So we offer individualized assessments for people who probably are really challenging for the teams that are looking after them. Sometimes I've worked in community for many, many years, and sometimes we can feel a bit defeated, a bit nihilistic. We've tried so many things, the person isn't really getting better. Sometimes it can really help to have a second opinion, think about things that may have been missed, or just have a fresh look at someone and have the opportunity to talk it through. We genuinely see our position as being one of providing support to the referring team in order that they can provide best care. We're not handing down gold standard practice from a textbook. We involve the referring team. with recommendation planning so that we can come up with recommendations that are practicable to deliver in that setting, be it rural, be it remote, be it metro. We've got a really broad scope. We'll pretty much assess anybody who's got psychosis, as long as they're on board with it. We do work to recovery model, and we really want individuals who are referred to consent and genuinely wish to be involved in the process, because we're trying to be directed by their goals as well as by the concerns that are elicited by the referring team at the point of referral. We do see people also for diagnostic opinions. So sometimes, several times, we've seen people where it's uncertain whether it is psychosis, and we're happy to assess those people also. So we are first a clinical service. We provide assessments for people across the state, and I'll talk about some of those people later. But we also have other sort of tranches of work which we hope to develop over coming years as we grow and develop. One is developing high quality training and education for clinicians and the broader community around interventions that are beneficial to people with complex psychosis. And these webinars are an example of that capacity building. We also have a number of research projects running, and we really hope to develop research into psychosis, particularly interventional research aimed at improving outcomes. So this is a lovely little flow chart which was developed by our social worker in our team, which really shows the process that an individual and their referring team actually will go through when you refer someone to our service. So you send a referral, we may liaise with you a bit to gather information after we've accepted the referral, and then we'll assess the individual either face-to-face here in Sydney or by telehealth. Then we come together as our team with all the multidisciplinary assessments and come up with a formulation about what the key concerns are, and then discuss those with you as the referrer at the case conference. We'll all be present, we'll feed back on our assessments, we'll ask the referrer, what do you think is possible? And we'll also have experts invited who may be able to weigh in and provide knowledge and insights about particular problems, for example, comorbid substance use or intellectual disability or neuropsychiatric issues. We then develop a collaborative care plan for the individual, and we feed back those recommendations to that individual and get their opinion on which interventions they're agreeable to and which not. And that again is very much based in the recovery model that we are promoting, trying really to ensure that we have the client, the individual, on board with all recommendations that are being provided to that person in their care plan. Then we will send a recommendation letter, and often this is a very detailed letter which has all the assessments made by the different team members. These can be very helpful letters in gaining evidence for an NDIS package or bolstering an existing package, for example. So we've had a lot of positive feedback about that process, which altogether probably takes about 4 to 6 weeks. And step 8, a number of individuals we follow up at 1 year to see how they're doing. And I'm going to talk a little bit about a subset of people that we followed up later in the talk. So I've talked a bit about the recovery model. This is really our underpinnings. And really what we're saying is that psychopharmacological management is the mainstay of treatment for people with psychosis. We know that antipsychotics are indicated. However, there are many more interventions which complement antipsychotics, which are also very valuable and evidence-based to reduce distress and symptoms and to improve cognition. And we really promote access to those interventions through our service. Similarly, we promote good physical health care, and everyone who's assessed has a physical health assessment by our TRSP affiliated GP. And this is our ethos. So what we really want is for people fundamentally to be assisted to achieve their goals, be minimally distressed by their symptoms, be socially included. And other things that people often ask about and wish for are that they might be able to work, whether supported or otherwise, to live independently and to have positive relationships. So I'm going to talk a little bit now about some of the recommendations that we made for people seen by our service over the first year and a half. So we've seen close to twice as many people as this now, but it takes us a little while to collate our recommendations and the outcomes. So I'm going to talk today about 82 people that we saw over the first sort of 12 to 18 months of the service being up and running. And you can see that in this slide, there are multiple reasons why someone might be referred to TRSP. And these numbers, you will note, don't add up to 100 because for many people, lots of these apply. But really what we're seeing a lot are people who have high illness burden, long duration of illness, multiple complicating factors. And who are the people? What do they look like? Well, most have schizophrenia, or about a third have schizoaffective disorder. Most are in their late 30s, though we have an age range from 16 up to late 60s. About 2/3 are male, about 2/3 have treatment-resistant illness, and most will have been unwell for at least 12 to 15 years. The PANSS score is a measure that you may or may not be familiar with. It's an indicator of how severe overall symptom burden is for psychotic positive symptoms, negative symptoms, and general symptoms like anxiety, agitation, etc. A score of 88 is a very high score. So we're seeing people with a very high symptom burden. And that's also indicated by another measure we use, the Clinical Global Impression for Schizophrenia. These people have very poor social occupational functioning. Some people just actually not getting out of their rooms, not getting out of their homes, with no relationships, no employment, no real activities, and declining NDIS packages. Or people who've been in hospital for 10, 15, 20 years. And because our wonderful neuropsychologists can complete a cognitive assessment on everyone where it's indicated, we have good measures of cognitive function. And we know that in this group as a whole, cognitive function is poor, in line with many of those people having a diagnosis of schizophrenia. So that's what the people look like. What do we tend to recommend for these people? Let's look first of all at the psychopharmacological recommendations. And we've included in this ECT as one possible recommendation, evidence-based now in the management of treatment resistance, where people fail to respond to clozapine or even as an alternative to clozapine. So among these 82 people, pretty much everyone got a psychopharmacological recommendation. In about a quarter, we recommended clozapine because some people had never tried clozapine. That doesn't mean it hadn't been offered by the referring teams over the years, but sometimes having a second opinion come in and say, I really think clozapine's warranted and you should give it a go, can just add a little bit of extra boom to a discussion. Many people were already on clozapine, but were on inadequate doses. So we recommended increasing the dose so that we got therapeutic blood levels, or augmenting the clozapine with agents such as amisulpride or aripiprazole. I won't go through in detail the other recommendations, but you can see that some of our work is around clozapine and treatment resistance, but by no means all. In fact, one important thing is that often people come to us on multiple antipsychotics, which can really contribute to adverse side effects. And if people aren't responding to one or two, the chances of them responding 3 or 4, there's not really a rationale or an evidence base for that. So actually what we're trying to do is reduce polypharmacy. And moving on then from the psychopharmacological interventions, I wanted to share with you some of the other interventions that we're recommending. So this graph shows the other domains of recommendations made. So we make neuropsychological recommendations in about 3/4 of people, provide psychosocial support recommendations in 85%, and physical health recommendations in almost everyone. So let's break those down a little bit. Talk about the neuropsych recommendations first of all. We know, in fact, that international guidelines suggest that individuals considered to have complex psychosis will benefit from a focus on recovery and rehabilitation that goes beyond symptom management alone. And cognitive remediation is an evidence-based therapy which is designed to help people improve their cognition and improve their function in real-life tasks in day-to-day life. And our neuropsychologist has run a very successful cognitive remediation therapy program within our LHD and can provide cognitive remediation therapy to individuals who are referred to TRSP who warrant it. It's not just about CRT though, not everyone will benefit from that. Other people may benefit from simple recommendations which can be put in place by carers, family members, support workers, for example, the use of visual aids or the need to break down tasks into small steps to help address recognition of poor cognition, reduced ability to take on information, reduced processing speed. And these are things that I think sometimes we miss in day-to-day clinical practice without that sort of neuropsychological input really informing how capable the person is cognitively. I want to talk a little bit as well about psychological interventions for psychosis. So throughout my training and the sort of 10 subsequent years that I worked in the UK, I was very lucky to work in a team where, as part of routine care, everyone was provided with psychological interventions for psychosis, CBT for psychosis, for example, acceptance and commitment therapy. There's a whole range of ways to help people manage their symptoms, learn about their symptoms, and find coping strategies to manage distressing voices, for example, paranoid thoughts. And there's a real lack of access to psychological interventions like that currently in Australia. We as a team have written about this, and it's something that I really hope we can develop as an intervention for the TRSP and for New South Wales more broadly over years to come, just in the way we have introduced cognitive remediation therapy. So I know this is very quick fire, but I'll move on now to talk about physical health recommendations. As I mentioned in the previous slide, almost everyone had some sort of physical health problem identified. The most common issues are cardiometabolic, which we know contributes significantly to the 15-year premature mortality in this group. So simple interventions which can be very effective are, for example, offering metformin to reduce the risk of development of diabetes, reduce weight gain, or management of diabetes if it is found that the person has that and is not receiving any treatment, which can be the case. We also really encourage that people are linked in with a primary care physician, a GP who's looking after them regularly and regularly monitoring and intervening where there are physical health issues. It's probably no surprise to people to see that over half of our individuals smoked, and often we offered smoking interventions, and about 30% of people were really interested to trial smoking interventions. So it is a bit of a myth that people with severe mental illness don't want to stop smoking. It's just that it's so very challenging for them to do so. It's hard for those of us in the general population to give up smoking, and think how much more challenging it might be if you have, a very isolated existence and very distressing symptoms. The work that's done by our occupational therapist and our social worker in particular really contribute to the psychosocial interventions that TRSP provides. So they both provide very detailed assessments of what an individual is capable of doing and what supports they're receiving from their network or family, and how that family might also require support. And as I said earlier, these reports can really enhance referring teams' abilities to get NDIS approvals through. Substance misuse is a common comorbidity in our group. For example, if this was the case, we'd have an invited expert come along to the case conference to talk about ways that people who are willing and motivated to quit might be supported. And I'll move on now to the next section, which is just briefly looking at a group of people who we saw and followed up at 12 months to see how they were doing after they'd been seen by TRSP compared to how they were doing before they saw us. So I'll just orientate you to the table. So in the second column, we have the baseline scores across scales that will be hopefully familiar to you. Let's look at the HONOS first. So a high score in the HONOS denotes a number of problems in their health overall. And you can see, incredibly, we didn't expect to see really dramatic changes in people's health, because these are very unwell people, and we expect to see small shifts as a result of intervention. But in actual fact, we saw HONOS scores drop by an average of 10 points a year after they've been seen by TRSP. And we saw LSP scores drop by about 8 points, which also denotes a significant improvement in someone's functional capacity. And these are mirrored in the SOFAs, which is about function, and the clinical global impression of schizophrenia, that bottom line, which is about severity of illness. So everything's going in the same direction, clinical and functional improvement 12 months after being seen by our team. We also looked at service utilization. So let's look at the left-hand side first. We've got the blue column, which is total number of presentations to emergency department in the year before people were seen by TRSP. And the orange is total number of ED presentations in the year after they were seen by TRSP. So they essentially halved. And looking at mental health presentations to ED, they dropped to about a third of their pre-TRSP level. So we're seeing improved clinical outcomes, improved functional outcomes, and reduced ED presentations, both for all reasons to present and for mental health reasons to present to ED. So what's the explanation for this? Well, my interpretation is that the really holistic comprehensive care planning approach that was adopted by TRSP and recommended to the treating team enabled the treating team to provide real wraparound containing care for the individual. And that helped better meet their mental and physical health care needs. and that helped to reduce crisis-related help seeking, and thus, through the dramatic reduction in acute use of emergency services. It's been really, really heartening for us as a team to see that people do get better. We're not taking the credit for that at all, because most of the work is done by the clinical team that individual goes back to the care of. We've just provided a place for the person to be thought about really comprehensively, and to provide a treatment plan which the referring teams are then putting in place, and the individuals are getting improved clinical and functional outcomes as a result. Okay, just in the last 5 minutes or so, before we move to questions and discussion, I'd like to just give you a flavour of what it is that we do in terms of research within the TRSP. A lot of the information that I've presented to you today was available to us because we have really detailed clinical and outcome data collection. So we have several research officers as part of our team who help enter data, which is scored. When assessments are conducted within the team, we do a normal clinical assessment, but as part of that, we'll also do some objective measures, for example, the K10, the CGI, ways to compare individuals over time and to compare severity of one individual with another. And that's really how we managed to collect all the data that I've been able to present you today. So beyond that sort of tracking of how people are doing in real time, we also have a number of projects which we've launched, and many of those are really with a focus on improving outcomes. I've mentioned already the cognitive remediation therapy implementation program, which has been led by our neuropsychologist, Chloe Gott, who is also completing a PhD on how cognitive remediation therapy can benefit people in complex psychosis. We also have a study examining a treatment for obesity and prediabetes, and another of our team members is conducting a PhD on the topic of trauma and shame and psychosis. We're really in the early stages of getting our research going, so if there are people out there who are interested in research and have ideas, we'd really welcome talking with you and collaborating. I'll just very quickly give you a flavour of what the cognitive remediation therapy program's like. So we recognise that core symptoms of schizophrenia, often forgotten when we spend so much time, thinking what are the positive symptoms, what are the negative symptoms. The cognitive symptoms are also very challenging and debilitating. Things like poor attention, reduced working memory, poor reasoning and problem solving, and reduced verbal learning. And these can really impact a person's ability to function in the community day to day, to catch a bus, to plan a route, to meet someone, to go shopping. And importantly, our Australian clinical guidelines for the management of people with schizophrenia and psychosis more broadly recommend that people should receive cognitive remediation therapy, but less than 10% of people with psychosis do in Australia. And that was one of the things that we were trying to challenge with this program. So we were enabled through philanthropy funding to train 12 therapists in New South Wales to conduct the Circuits program, which was developed at the Institute of Psychiatry in London. It's a cognitive remediation therapy program which is accessed by the individual online in a computer screen, and the person's supported to go through tasks which are tailored to their ability by the therapists. So if you'd like to know any more about cognitive remediation in general, or about the program run in TRSP, I've included Chloe's email there on the slide. And finally, I'll just talk a little bit, just give you another flavour of the type of work we're doing. We have been running a clinical trial of a treatment called semaglutide, which many of you may be familiar with through TikTok. It's been an absolute global sensation for weight loss, and that delayed us getting the treatment available to give to people with complex psychosis. The PBS allows us to prescribe it here for people who already have diabetes. We wanted to give it to people with complex psychosis who were at high risk for the development of diabetes, but who didn't yet have it. So people who are very overweight, obese, and have, higher resting blood sugars, but not yet at the threshold for diabetes. And I'm sure there would be many people in your caseloads that you can think of who meet those criteria. So I won't go into too much detail, but semaglutide is an example of a fairly new type of treatment for the management of diabetes. Previous studies have looked at this class of drug in schizophrenia. We think semaglutide is a bit better because it can get greater weight loss over a certain period of time and only needs to be given once a week by subcutaneous injection into the tummy. So we have conducted this study over the past 18 months, and we have had 17 people complete the 24 weeks of treatment. About 9 withdrew, mostly due to nausea or not wanting to come for weekly visits. And we hope to be able to talk more about how successful semaglutide was in helping people lose weight in future talks. And that's really all to say, except that these studies are just the starting point of what we hope will become a much more developed research program over years to come, all really with the focus of improving clinical and functional outcomes for people with complex psychosis. And I think I'll finish there. I'll stop screen sharing in a minute or two, but I would really welcome you now, if you can, to add any questions to the chat. And while you do that, I will just share that TRSP webinars will be returning in March next year. So please look out for information from us. And if you do want to get in contact with us to make a referral or learn more, that's our email address on the screen. Thanks very much. So I think, Sarah, you're going to share some polls for everybody in the audience. And meanwhile, I'll go through a few of the Q&A. So Benjamin has asked, sorry, the polls just come up. How can we refer patients to your trial of semaglutide? Do they have to have gone through your full assessment process first? Benjamin, that trial has actually concluded. It was open mainly to people who lived in our LHD so that we could meet with them weekly. But certainly if we have future studies and they were available to people more broadly in New South Wales, we would make that well known through the webinars and through our emails. And someone has asked, did the patients who were not diabetic have to pay non-PBS price? It was run as a clinical trial, in fact, so there was no cost to anybody for participating. And Benjamin asks, our early intervention service had a patient in mind to refer, but he declined. Do you have any experience with the reasons patients might be reluctant to see you and how to address these? Yes, look, that's a really good question. Benjamin, actually, we are very people are on board with seeing us because the assessments are quite involved. And, you know, if people don't want to talk to us, we're limited in what we can do. We sometimes can see people who are passively consenting, but it's with the caveat that it's less likely that we'll be able to get a really good information from the person. Having said that, there are many people that we've seen who are maybe like a little bit reluctant to see us, and we have some really skilled clinicians who are very able and adept at developing sort of therapeutic alliance and engaging people around topics that they feel important to them. So one suggestion I might make, Ben, is that if your client were willing, for example, to speak to our peer worker, someone with lived experience of mental illness, first of all, just to hear a little bit more about our service and hear what's involved in an assessment, then that's something that we could certainly arrange. And Helen has asked, do you have any age limitation, meaning do you see people over 65? Helen, that's a great question. Thanks for that. We see people who are cared for by adult mental health services. So if a 70-year-old fit and healthy and being looked after in adult mental health services, we're happy to see that person, but we don't see people who are cared for in older persons. And Meg McGregor has asked, what's your capacity like for referrals? For example, if referred from Newcastle area, is there a wait list? Thanks for that question, Meg. That actually depends on really how many referrals we have in the bank at the time that you refer. So sometimes we get to the sort of the end of our referral list and we start contacting people who've referred to us before and said, you know, is there anyone that you'd like to refer? At other times we have 10 or 12 people on the list waiting to be seen, and those people, it may be, you know, 2 or 3 months before we get to them. But normally, if that's the case, if we're not going to be able to see people within about 4 to 6 weeks, we would advise you of that at the time. And that's true regardless of wherever you are in the state. It doesn't matter whether you're Newcastle, Broken Hill, Murrumbidgee, anywhere. We treat all referrals the same in terms of the ones that come in. We try and see those in the order that they're referred. We've got a question from Nicole. Does the evidence suggest schizophrenia is a single illness or a group of illnesses? Is it a neurological illness or group of illnesses that in some cases may benefit from different interventions? So Nicole, that's a great question. That's a really big question. I would say that my view on this is that there are many pathways into psychosis. Some people have neurodevelopmental loading, some people have genetic loading, some people have childhood adversity, some people have access to drugs and alcohol, and all these factors, genetic, environmental, and individual, can impact an individual's likelihood of developing schizophrenia. And I think it's really important to explore and really thoroughly understand the route that people came to psychosis through. So if it's a more neurodevelopmental picture, are there ways that we can assist them with their cognition, with other neurodevelopmental challenges? It's likely that if we target our interventions and tailor our interventions for the underlying difficulties, for example, addressing trauma, which has never been addressed, then those are likely to result in benefit. I don't believe that treating schizophrenia is a one-size-fits-all model. I think that might be, no, we've got one more from Mary Louise Singh. Can you refer if the person you support is not with the community mental health team? You can, Marie-Louise, if they're in an inpatient setting. If they're cared for in public mental health services, we can see them. And I see that everyone has completed the poll, so thank you very much for that. We will utilize that information to plan our webinar series for next year. Thank you very much, everybody, for attending today. And thank you very much for being part of the audience throughout this year. We will be back in March 2024. So between now and then, I hope you have a lovely holiday period, and thanks very much. Bye.